Now, sir, we have the last session with us. So we'll proceed for the last session. So thank you for joining with us. And the last session is Edward I. Muser session. He won the Nobel Prize in Physiology or Medicine 2014 for their discovery of cells that constitute a positioning system in the brain. And for this session, we have the chairperson with us, Dr. Hina Goswami from Jamnagar and Dr. Tanish Modi from Ahmedabad. I welcome you both and I request Dr. Hina ma'am to introduce our first speaker.
Thank you so much Dr. Yash Patel sir, Dr. Mayur Patel sir, for giving me this opportunity. I will first introduce Professor Nihal Thomas sir. His qualification is MD, MNAMS, DNB Endo, FRACP Endo, FRCP and FACP PhD Copenhagen. He is professor and head of endocrinology unit 1, former deputy medical superintendent, vice principal research and association director in CMC Vellore. Over to you, sir. Dr. Professor Nihal Thomas.
Good day to all of you, and I would like to thank the organizers, including Dr. Mayur Patel and Dr. Mona Shah, for their support in this regard in inviting me to give this talk. My talk is going to be on algorithmic approach to diabetes in the young. So we're all aware of the landmark study which was published in the year 2018 on the burden of diabetes across India. And we can see the differential prevalences in different states across the country. Having said that, there's a massive increase in the prevalence right across the country, all throughout India. If you look at the prevalence of diabetes, this is largely a study which has looked at diabetes in adults. Having said that, if you take into account the proportions of patients who are less than 30 years of age, as you can see from this particular slide, is that up to the age of 30 years, there's about 2.3% of patients in the year 1990 and about 2.7% of patients in the year 2016. Essentially, there is a five-fold increase in total number of patients with diabetes over the last 25 years or so. We can see quite clearly that it has amounted to almost 1.1 million patients with young onset diabetes in the year 2016. If we were to look at this from a scientific perspective, the WHO classification now states that the various forms of diabetes include type 1, type 2 diabetes, hybrid forms of diabetes, and other specific types. And I shall go through the young onset forms of diabetes and try to give you an algorithmic approach towards trying to diagnose this problem. So the most important fact is that one has to take into account a good history. Draw a pedigree chart with the family tree, looking at other individuals who have diabetes or even other disorders which may be associated with several genetic conditions. Do a proper physical examination looking for dysmorphic features. Check C-peptide levels in the fasting and postprandial phase. Measure GAD antibodies to look at the evidence of autoimmunity in type 1 diabetes, and doing imaging of the abdomen to look for pancreatic pathology as well. Beyond this, the other tests which are done are in a tertiary or quaternary care center, and I shall allude to these as the talk goes on. So let me first start by leaving out type 1 and type 2 diabetes for the beginning, because type 1 diabetes is the commonest form of diabetes in the young right across the board. And essentially it is an autoimmune disorder. Yes, we know that. And 80% of these patients have GAD antibody positivity with low C-peptide levels at the time of diagnosis. So I shall go on to the differential diagnosis by looking at other conditions, and I shall start with the hybrid forms of diabetes. Here is a 29-year-old male who comes with polyuria and weight loss over the previous 4 months. He does not have abdominal pain or steatorrhea. He has a low BMI at presentation, and his urine ketones are negative. He was given a trial of oral antidiabetic agents by his local practitioner for the first 1 year, but then required insulin thereafter. His GAD antibody titers were elevated at 2000 JDF units, which is extremely high, and he had a normal imaging of the abdomen with low fasting C peptide levels once his glucose control was appropriate. And this tells you that this patient has evidence of beta cell failure and an autoimmune etiology. And even though he was managed with oral antidiabetic agents in the initial phase, he has an insulin dependent form eventually. And this is now called the slowly evolving immune mediated diabetes of adults, which is formerly called LADA or latent autoimmune diabetes in adults. The age of presentation is generally over 35 years. Having said that, taking a cutoff at an earlier point of time with autoimmune islet cell markers would make this diagnosis. Generally, when we treat these patients, we will find that they behave a lot like type 1 eventually, and basal bolus insulin is the most appropriate form of treatment, though a small proportion may get away with premixed insulin on a twice daily basis. We go now to another form of diabetes in the hybrid group, which was initially reported from Afro-Americans and Oriental populations. Unprovoked ketoacidosis at the age of more than 30 years in general, and autoimmune antibodies are generally negative in this phase. They have this explosive presentation in the initial phase, but subsequently over a period of a couple of months, the insulin requirements come down drastically and they can be managed with oral antidiabetic agents. First, this was described in Brooklyn in New York in a suburb called Flatbush and is therefore labeled as Flatbush diabetes. Its onset resembles type 1 diabetes, but they have the features of the metabolic syndrome at the same time with some features of insulin resistance. And so they are variably called atypical type 1 diabetes. This was the first publication from India in this regard and has confirmed, therefore, that Flatbush diabetes or ketosis-prone diabetes is present in the Indian population. We have looked at these patients on a serial basis, and inevitably, patients who present with ketoacidosis who are GAD antibody positive, who have some features of insulin resistance below the age of 30 or just around that age, may in fact more likely have ketosis prone diabetes rather than classical type 1 diabetes. So essentially 32% of unprovoked diabetes ketoacidosis in young Indian adults may in fact have A minus, B plus KPD, which is basically antibody negative ketosis prone diabetes. They tend to be on the overweight side. They are generally males in most situations. And they have a strong family history of type 2 diabetes and are antibody negative. The beta cell function, which appears to be diminished at the initial phase, once good glycemic control is achieved, they have a good postprandial surge of C peptide at the end of 1 year at follow-up. Insulin can be discontinued in all patients who have ketosis-prone diabetes or the Flatbush diabetes. I go on next to the other specific types, which covers a vast gamut of inherited conditions and genetic conditions, which include both the beta cell secretory defects as well as the defects in insulin action. So, talking first about MODY or maturity onset diabetes of the young, which is essentially 2 to 4% of all diabetes, an age of onset of less than 25 years, a 3-generation family history, and generally non-insulin requiring in the initial phase. They are thought to be monogenic. However, I will show you that certain cases can be bigenic or even trigenic for that matter. And they are usually associated with a non-obese state. Having said that, nothing prevents them from becoming obese. If you look at the WHO classification, it alludes to a lesser number of inherited beta cell defects when compared to the classical MODY classification of 14 types. And you can see over here that the commoner Western forms, so GCK MODY, HNF1 alpha and HNF4 alpha, which is essentially MODY 2, 3, and 1, I have been put at the top of the list, followed by MODY 5. The mitochondrial mutations as well have been included in this inherited form of diabetes. In addition to this, you have the Wolfram syndrome, the IPEX syndrome, which may be also associated with an inherited form of Diabetes and Walcott-Radisson syndrome, which I will not be talking about in that much detail in this particular lecture. So these are the forms which we have picked up frequently in our Indian population as well in our studies at Vellore. And so also the ABCC8 MODY, which is initially thought to be largely neonatal, is also found in adults in addition. This publication will tell you a little bit about our own experience. Here is an 8-year-old girl with a 3-generation family history. Look at the pedigree chart. You can see a number of individuals in the family have a strong family history of diabetes on the paternal side in particular. And she was found to have a glucokinase mutation or MODY2, which is in fact not that common in the Indian population. Here is a 25-year-old female in the bottom half of the slide with the first trimester miscarriage at 6 weeks, given metformin, not controlled, subsequently given glibenclamide. She had an inherited form, and you can see over here there are renal cysts, which is classical of MODY5. And here is a young man, as you can see the arrow over here. You can see a patient wherein you have the index case who has a requirement of both insulin and oral anti-diabetic agents at the same time, wherein he has 2 mutations, a PAX4 and an ABCC8 mutation, wherein one parent has only PAX4 and the other one only ABCC8, and they are both being managed only with oral anti-diabetic agents. So a digenic mutation which is leading to an increased so-called dose effect of genetic material, which leads to more severe diabetes. MODY can present even in pregnant women, and this should be considered in the differential diagnosis of young, lean pregnant women who are less than 25 years of age. They very well may have MODY if they're particularly present with gestational diabetes before the 24th week. The common mutations here are different from what is seen in the Western populations, which include the PDX1 and the NeuroD1 mutations, MODY4 and MODY6. So MODY is seen more commonly than what we used to think. A number of patients who have inherited diabetes may in fact have MODY. The Indian forms are different, MODY6, 4, 12, and 13. Large volume of these patients can be diagnosed later on in adulthood after the age of 30 and may be missed in childhood. Pregnant women who have diabetes with an autosomal history may in fact have MODY, and MODY could be digenic in origin. I was talking to you about the inherited forms with beta cell dysfunction, and mitochondrial mutations are also important. Here was a lady who was in her late 20s. She had lean diabetes for 15 years. And then all of a sudden, her daughter presented with muscle weakness, with a myopathy. We look for inherited causes, and because of the myopathy, a mitochondrial mutation was looked for, and we can see over here that the severity of the mitochondrial mutation is more intense in the child. Therefore, it presents early on with muscle weakness, whereas in the adult who came first at 28 years and eventually was proven once the child was shown to have a mitochondrial mutation, had a low heteroplasmy, and therefore it was only next generation sequencing as a genetic testing which picked it up in our lab. So mitochondrial disorders are not that uncommon. We classically think of them as a maternal inheritance. Having said that, we can have nuclear DNA which can cause mitochondrial mutations in addition. And over here you can see the young girl who had myopathy and the typical ragged red fibers which are seen on the Gomori stain on the biopsy. Mitochondrial diabetes may have multiple organ involvement, and of course in other members in the family who may not have diabetes, they may have a totally different presentation, and therefore look for diverse presentations in family members. Hearing defects with cochlear involvement with sensorineural hearing loss is the commonest occurrence, and therefore one member may have deafness, another member may have diabetes, someone else may have epilepsy, and a third member may have myopathy. So diverse presentations of different clinical disorders in other members of the family. Coming down next to the other specific types in terms of insulin resistance defects, you can see the WHO present classification over here shows various forms, and essentially the first three types, or particularly the second and the third types, such leprechaunism and Rapson-Mendenhall syndrome, occur in small children. They may be lethal at an early age and are associated with the mentally challenged state. So that's not so important from an adult perspective of inherited diabetes. But look at the others at the bottom. And here, let me illustrate the case histories of a few patients. We have an 18-year-old female with diabetes detected at the age of 15 years on premixed insulin since onset, poor glycemic control, and was recently shifted onto a basal bolus regimen. There was no history of diabetic ketoacidosis, and she had profound hypertriglyceridemia with triglycerides more than 1,000 from the age of 15 years. She was irregular with her treatment, having the normal issues of stress and frustration as a teenager, and would skip her insulin doses, but she never would develop ketoacidosis on stopping insulin. And she had hypertrophy of the muscles in addition. So you can see over here that we measured the C-peptides and found them on the higher side. She also had fasting insulin levels which were elevated, and the HOMA-IR was also increased, indicating insulin resistance. And the triglycerides were markedly elevated in the daughter. The mother was, of course, on treatment for hypertriglyceridemia. So you can see over here an inherited condition wherein there is also an abnormal distribution of fat. When we did a DEXA scan, which we normally use for osteoporosis, we found that the distribution of fat was abnormal and lower in the lower parts of the body and higher in the upper parts, particularly the head. And this is a partial lipodystrophy. We established the diagnosis with the next generation sequencing and locating a laminin gene mutation over here. Here is a complete lipodystrophy, or the Bernadelli Seep syndrome, wherein there is stunting of growth, total lack of subcutaneous fat right across the body, and the MRI also showing virtually no fat in the subcutaneous as well as the intra-abdominal area, indicating that there's a gross anomaly in the phenotype, and the mutation being more severe, leading to severe insulin resistance, high C-peptide levels and insulin levels, and they are prone for fatty liver and cirrhosis at an early age. They can also present with a polycystic ovarian type of phenotype in addition. The other inherited genetic syndromes are vast, and here are the commoner ones which have been included, some of which, from a physician perspective, can be easily diagnosed with their typical features: Down syndrome, Klinefelter syndrome, Turner syndrome, and of course, the history in terms of menstruation, abnormal sexual development, etc., can be picked up over here fairly easily. And the syndromic obesities like Prader-Willi syndrome and Lawrence-Moon-Beetle syndrome can also be diagnosed clinically and ultimately proven with genetic testing. There are many other syndromes where these diabetes of inherited forms can actually occur. And here is one patient who presented with hyperglycemia along with pigmentation, hypertrichosis, short stature, hypogonadism without an elevated FSH, which indicates that short stature with amenorrhea. You think of Turner syndrome, but here the FSH was not elevated, and a hearing loss along with cardiac involvement. So this is called the H syndrome, and once again, genetic testing showed evidence of mutations in the SLC29A3 gene, and here once again we have the presence of next generation sequencing helping in establishing the diagnosis. This is also of the endocrine pancreas. So fibrocalcic pancreatic diabetes is of course typical to tropical areas and can present with abdominal pain, maldigestion with steatorrhea. In the second decade of life, they tend to be lean with low BMIs, and by the time they reach the third decade, they have diabetes. And of course, sometimes the diabetes can come earlier in the second decade. They are classically diagnosed with low C-peptide levels and an ultrasound or a CT scan showing a shrunken pancreas, significant duct dilatation, and intraductal calcification in addition. Now, what you can see over here is that the insulin secretion rates in fibrocalcic pancreatic diabetes, when compared to normals or in the phase of evolution before they have diabetes is significantly lowered. In addition to this, they have anomalies in energy expenditure. Indirect calorimetry in these patients is evident that there is a higher than expected energy expenditure, and therefore these patients, besides poor glycemic control and fat malabsorption, are slim also because they burn a lot of energy more than expected, and therefore the dietary requirements are much more than what is usually prescribed to them. They may have requirements of up to 2000 or 2500 calories per day. The glucagon secretory rates are paradoxically high, and one would not have expected this in a fibrotic calcified pancreas. The issue is whether the glucagon is being secreted from other sites, perhaps the L cells, and we have evidence to back this up because the GLP-1 response to oral glucose tolerance tests is in fact accentuated in these patients with fibrocalcific pancreatic diabetes. And in addition to this, the oxyntomedulin response also you can see over here is anomalous. So basically, this indicates L cell hyperactivity, and we believe therefore that the L cells may regress into producing some of the pro-hormones, which include glucagon in addition. So in summary, fibrocalcific pancreatic diabetes is insulinopenic with low C-peptide levels, and they essentially require insulin treatment, prone for hypoglycemia, high carbohydrate diet, and a high propensity for pancreatic cancer. Coming down to a form of diabetes which was once part of the WHO classification way back in the 1990s, but has been since then removed, is the protein deficient diabetes mellitus, or a subgroup of malnutrition modulated diabetes. Malnutrition is still a problem in India, and if you look at the map, the yellow color indicates that about 15 to 20% of children born in the country are in fact malnourished. And this postnatal malnutrition can lead to anomalies in pancreatic function and may even lead to beta cell defects in impoverished parts of the society. The classification has actually shown that this form of diabetes is associated with fasting hyperglycemia more than 200, usually an onset before 30 years, but generally more than 15 years of age. They are lean with very low BMIs, very often less than 19 kg per meter squared. They do not have ketoacidosis, and they belong to a low socioeconomic stat, but they have normal exocrine pancreatic function. So here we can see over here that they have beta cell dysfunction, but the insulin levels are not as low as those with type 1 diabetes mellitus. The other feature is that of fat distribution in the body. They have visceral fat, which is more than type 1 diabetes, but much less than type 2 diabetes. But more important is that the pancreatic fat content, and you can see the blue bar over here, is that the MRI shows that the pancreatic fat content is more than any other form of diabetes. Now, what this means, and does it have some impact on beta cell function, we really don't know. So let me summarize. In patients with malnutrition modulated, or the protein deficient form of malnutrition modulated diabetes, have insulin deficiency, low hepatocellular fat than type 2 diabetes, low visceral fat content, and exceedingly high pancreatic fat content. So physiologically, these are not a lean variant of type 2 diabetes, which has been a misnomer where they have been called this. They are very different and they require insulin treatment, but they are not prone for ketoacidosis. Type 2 diabetes in young individuals is the final condition which I'm going to be talking about over here. But young people, when you think of type 2 diabetes, please rule out all other forms of diabetes first. Think of MODY, rule out lipodystrophy, rule out other conditions wherein there may be an overlap with obesity and a syndromic form of diabetes. They may have IGT and IFG in childhood, which may progress to diabetes. They are generally obese. They may have had poor nutrition in pregnancy and therefore low birth weight, which ultimately leads to a thrifty phenotype and therefore subsequent diabetes at a young age. And they may have had a psychological stress factor. Children these days are prone to a lot of stress in their studies in school. They are not usually primed to cope with these stresses. Death of a family member or a brother or a friend or some break in friendship, and these are all factors which may have a significant impact on the hypothalamus, which may lead to defective uh, homeostasis and subsequent young onset diabetes in these individuals. So when you have young people with diabetes, what should you think about? We have this massive list of conditions, but if you have a systematic way of approaching it, now you can make an appropriate diagnosis in a young age for young onset diabetes. The commoner forms include fibrocalcic pancreatic diabetes, MODY, ketosis prone diabetes, and type 2 diabetes in the young individuals. Type 1, of course, is the commonest form. And then, of course, after you've ruled out type 1, you think of these other conditions. You need to have an approach in terms of looking at the habitus. So as over here, I've shown you quite clearly that type 1 have a lean habitus, type 2 are overweight. You need to look at the C-peptide levels. In type 1, they are low. In patients with fibrocalcic pancreatic diabetes, they are low. And in MODY, they are intermediately low. In patients with lipodystrophy, they are elevated. In type 2 diabetes, the C-peptide levels are elevated. And the age of onset can be different, which may also help. Type 1 can occur after the age of 6 years, but right through childhood into adolescence. Type 2, between the ages of 10 to 30 years, of course, more than 30 years, type 2 could also occur. And maturity onset diabetes, depending on the neonatal forms, could be even from birth onwards, right into adulthood, depending on the various types of MODY. Lipodystrophies generally occur less than 20 years, and ketosis prone diabetes more than 25 years. The protein deficient diabetes occurs later than type 1 diabetes, between the ages of around 15 to 30 years. It's important to remember that GAD antibodies, C-peptides, and ultrasounds are the most important lab tools that you need to use in all your patients. And remember, a lot of type 1 and fibrocalcic pancreatic diabetes is being missed because these tests are not being done. I'm reiterating that in primary and secondary care, you can do most of the tests, or rather evaluation, in young people with the areas which are marked in white on the slide, and the other areas in yellow indicate that they are quaternary care. So you need to refer the samples, at least. You don't need to refer the patients. Samples can be sent to a quaternary or tertiary care center in the country to look at genetic testing, Sanger sequencing, and other forms of genetic testing. I'd like to acknowledge a number of colleagues who have helped in developing the clinical services and the lab for genetics in our institution and have taken things forward as far as young onset diabetes is concerned. Thank you very much for your patient listening. I'd be very pleased to answer any of your questions.
Thank you so much, sir, for such a wonderful session. And the questions we'll take at the end.